you can measure the central venous oxygen saturation continuously. The principle used here is spectrophotometry. You have the RBC in the venous system or in the pulmonary artery, and you have a light emitting diode which sends the light, and the refracted light is detected by a photosensor through a fiber optic bundle. Later it is processed to get a digital value. Here you can see the saturation around 70%. So, two things are required. One is the catheter and another is the fiber optic bundle at the distal tip of the catheter. Here this is the oximetry port which sends the signal, and later it is reflected back, and here you can see the mixed venous oxygen saturation as a digital value. This is the port which is connected to the machine so that the oxygen saturation comes as a digital value. So, you have a optic module with a cable connected to the monitor. First you do in vitro calibration before insertion. Here you should not flush the catheter. You enter the lab value of hemoglobin and hematocrit. In vivo calibration after insertion of the catheter into the PA. Here you withdraw 2 ml of sample and send to the lab. You enter the value of hemoglobin, hematocrit and saturation for calibration. This is in vitro before inserting and in vivo after inserting. Here while in calibration, you enter the height and weight and you get the body surface area. Once you enter the value, you get the cardiac output after entering the other variables. But with regard to oxygenation, you enter the FiO2, PaO2, PCO2 which is obtained from the ABG, and from the pulse oximeter you record your arterial oxygen saturation. As you enter all the variable, you get what is the SpO2 which is the mixed venous oxygen saturation. For this you have to enter all the variable and you have to calibrate, and then you get the value. Here you can see the value is being entered, and you have to enter the hemoglobin value too, and you have to enter the atmospheric pressure also. As you enter it, you can see all the content, venous oxygen saturation, everything comes into picture. Even oxygen consumption and extraction also comes in. Similarly, you have a optic bundle catheter for central venous line. Here it will be in the SVC and the same principle will apply. Here you can see the cardiac output and the central venous oxygen saturation. This is the continuous value. Here you see the value but no digital display is there. Why it is happening? You can see the continuous cardiac output but there is no value on the SpO2. This is because we have to monitor what is called the signal quality index. What is this signal quality index? If it is at level 1, the signal is normal, all aspects of signal are optimal and you will get a value. If the signal quality index is at level 2, it is an intermediate signal and it indicates a moderately compromised signal. If signal quality index is 3, the signal is poor and it indicates poor quality signal. And finally, if the signal quality index is 4, it is unacceptable. It indicates severe problem with one or more aspect of signal quality. So, it is always signal quality index of 1 should be there for a good digital display of the mixed venous oxygen saturation. And coming to a few salient points of mixed venous oxygen saturation, the calibration should not be more than 24 hours old. It should be calibrated every 6 to 8 hours. Signal quality index should be at the level of 1. Signal quality may be compromised if the PA catheter contacts with the vessel wall, or there is a kinking in the PA catheter, or some clot or hemodilution happening inside the lumen of the pulmonary artery. Recalibrate if the hematocrit changes by 6% or the hemoglobin changes by greater than 2 gram per deciliter. Electrocautery, try to keep it a far distance from the monitor and the cable. Reposition the catheter if the signal is not good. Aspirate and gently flush the distal lumen so that a good digital PA trace comes.